Hi, guys. Thanks for joining. This is Essence of Medicine. Today we're talking about radiculopathy. I'm Amanda Armagast.
Dominic Moore.
And I'm Dr. Abbasi for Essence. Radiculopathy, that is a very specific term.
Yep, it's part of our term series.
Yeah.
Dominic loves the term series, so I'm keeping it going specifically for him.
You're not supposed to tell him that.
He hates it.
I think, Dominic, half of you is out. If you need to get closer so you're in the field. I don't know how other people see you guys, but yeah.
Sorry, Amanda. I hope it doesn't smell too bad.
Look at that bow tie. My God.
Oh, thank you. It's coming off instantly after this.
Yeah.
I love the shirt, actually.
Yeah. So what do you understand on the radiculopathy, Amanda?
I understand that it's when your pain is radiating.
Mm-hmm.
And is it usually in the chest?
In the chest?
Is it usually in... No, it's not always in the chest. It can be anywhere in the spine.
It can be anywhere in the spine. It can be absolutely anywhere. And Dominic, tell me a little about the radiculopathy.
Yeah, so radiculopathy is usually very specific for when you have. Let me dial it back just a little bit. So it comes from those terms. We always have apathy, which is the disease of suffering from, and then the first part, radic, usually comes from I think it's Latin, might be Greek. Sorry, radix, which is root. So it's some sort of disease of the root. So it's when the nerve root is compressed to the point where you get some sort of symptom. So usually they have these wonderful distributions where they shoot down a very traceable area or a pattern that you can kind of see and go, yep, that's radiculopathy there. That's radiculopathy from this, or at least adjacent or somewhere close. I'm pretty sure the most common ones are going to be in the base of the cervical spine and then the base of the lumbar. So those usually hands and legs there.
So is that when patients have nerve root irritation, it's radiculopathy, or are those two separate things?
They can have symptoms that look similar, but radiculopathy is because it's currently being compressed, or something's working on it right now. The nerve root irritation is something that will go away eventually because it's just been irritated. The radiculopathy is constant irritation.
So nerve root irritation will go away on its own usually, whereas radiculopathy needs assistance to go away. It won't just resolve itself.
Yeah.
Okay.
But how's it sound to you?
Sounds good to me, but you know what's coming, right? You know what's coming.
1 million years ago, when the spine was created, the first spine ever.
It is your fault, so I cannot help it. I cannot help it. It's a crime story, and like anything else, you cannot see. Anatomy, especially neuroanatomy, is so heavy. So it crushes you until you understand the background of it. Then you fall in love with it. Are you looking at your watch, Amanda?
Sending you a text.
We have only 15 minutes.
Hold still a little bit because I don't know if it's just your internet or if it's ours, but you're really creeping me out. Do you see what I see?
I don't know what you're talking about, Amanda. I don't see anything.
Your internet's really laggy, or maybe it's ours. So when the first half of your head moves, the other half stays here, and then it say stop moving around.
It's like he's made out of a slinky.
But that's so fitting because that's how our body's made.
He's moving in segments with his vertebrae, actually. Yeah. This is perfect.
No.
He's doing on purpose.
How many segments make our brain?
Oh my gosh.
Oh, 12.
Yes. How did you know?
Well done.
The brain was actually my favorite unit in psychology.
Yeah. No. Okay. Let me see if I can share my screen, because you have to see that. You have to fall in love with it. Then you won't forget about it. Okay? Screen. Here we go.
There we go.
These are the dermatomal, how our body is divided, meaning every single nerve that comes out of our body goes to one of those segments. And radiculopathy is when you have a pain, numbness, tingling, mostly pain, along those dermatomes. So meaning that if the pain, you remember, Dom, when I go ask the patient, is the pain in the front of the thigh, side of the thigh, or back of the thigh?
Mm-hmm.
That already gives you a good answer about where to look for. But why are those segments so funny? In the torso, it is clear. But look at it, how funny it is. Look at that. Like we have the S1, S2, S3, S5. Just the anus is S5, whereas heel is S1, and then there's nothing here except S1, S2, and so on. Do you see how funny it is? And head. What's going on with the head? Why isn't the head like that? Because the head is made of practically the front segment of our embryonal tube, and the cranial nerves 1 to 12 create our literally the head dermatomal distribution, which is very different because over millions of years, it has been organized it in that way. Now, okay, let's understand that. First, you're a bunch of cells here, okay? You're a bunch of cells, and those cells eventually, they make a tube. It's called the neural tube. The neural tube is still not what really makes the impact. Under the neural tube, there is a cell islands that are called the notochords. Okay? The notochord is practically a small little piece of a tissue, some cells right here. This is the neural tube. This is the notochord. This notochord is practically the boss, tells what's supposed to happen in that segment. If you take a notochord from this area that is for the arm, they have done it with frogs. You take that away from that area, you put it somewhere else, another arm is going to grow in that location. Because that dictates where a nerve, artery, and vein distribute. And now all of a sudden you understand that how these segments come to be. Okay? Each of these is a segment. The first 12 segments become our brain and the nerves associated with that. And then we have 7 cervical, 12 thoracic, 5 lumbar, 5 sacral, and then they grow along the way. But let's go back to this. Why? Why is it so different? That it doesn't look like it's a segmental, except let's look at how an alligator looks like. Okay. So look at the alligator here. You see, his arm and hands are not front and back. They are somewhere in the middle. Mm-hmm. Okay? And look at how the alligator is using. If you took the segmental of alligator, you can just slice it, and even the hands and the fingers. But those distribution stayed the same, but we are using our hands and legs in a different way, so they are twisted. That's why they're so twisted. But an alligator is literally walking like with their arm and hands like that, with the thumbs forward, pinky, the last one. That's why it's C6, 7, C8. Because alligator walks like that, okay? And human, no, though, we took it completely out of context. We lost our tail. So S1, S2, S3 doesn't really do anything for us. But our anus is still the very last segment. And look at the arm and hands. Imagine that you go on all your fours, you put your thumb forward, and then you turn your knees outward like alligator. You try to play an alligator, and then we come and cut you in pieces. Then those segments exactly align. So, and each of those are based on a notochord telling to that segment how the nerves should distribute. Now, those nerves, by the way, even the sad story is notochord is the boss until our body is built. Then it has to actually go away. It becomes the center of the disc, because if it was still there, it would grow more stuff in you that we wouldn't be needing it, right? So it is a good developmental thing, but it literally vanishes away. And now it becomes the center of your disc, and the bone grows around that. But the nerves that it causes to grow, not surprisingly, as well take off exactly where the disc is. Exactly where the disc is, the nerve takes off. Again, not surprisingly, because it is based on the notochord, which become the center of the disc, telling you grow and you do this. Now, let's go back and talk about radiculopathy. So, spine anatomy. Here it is.
Oh.
So we have 5 lumbar, 12 thoracic, rib bearing, 7 cervical. Between each 2 bone, there is a hole. We call that, what do we call that?
Foramen.
Foramen, meaning the hole.
Mm.
And then a nerve is coming out there. Whatever push on that nerve, doesn't matter where, it causes radiculopathy. So, now there are a few tricks here you need to know. Anybody in medicine need to know. Amanda, you don't need to know this, but
How do you?
in medicine need to know. The first one comes above the C1, and then C2 comes above C2. In cervical spine, the same numbered nerves come above the bone. But then we have a C7 and then C8 nerve root, but we don't have a C8 vertebra. C8 nerve root comes between C7 and T1 vertebra, correct?
Mm-hmm.
Dominic?
Yep.
Where is, show me your hand where the C8 distributes.
Like
Pinky.
Pinky.
over here.
Yeah.
Oh, there we go.
C8. You see that there? Right there.
You were spot on.
Okay?
And it's part of the ring finger too over here.
Part of it? Not the whole one?
So,
Not the
Yes.
whole ring finger, just part of the ring finger?
half of it. Half of
Half
it.
of it.
Hmm.
Now, in cervical spine, the nerves come above the same numbered vertebrae. In thoracic and lumbar spine, because we have a C8, one additional, don't ask me how they did that. It comes below the same numbered vertebrae, meaning that where does the L5 nerve root comes out?
Yeah,
No,
right.
but between what bones?
Oh, S5. Sorry, S1 and L5.
L5, S1.
Mm-hmm.
C5 comes above C5. L5 comes below L5. But that is still not the whole story.
Ooh.
Okay?
Getting
Yeah.
me excited.
Yeah. Now, let me tell you why it's not the whole story. Here, let's look at that. Are you able to see that, this cross section?
Yeah, but if you click it, it'll be bigger.
No, it's not bigger. Okay, here. You see,
Get rid of the add to, please.
I don't know how to do that, but let's watch
Looks
that.
dead anyways.
Now, the nerve takes off, passes in the lumbar spine one segment below, and then comes out. We have cauda equina. When we grow here,
Mm-hmm. The horsetail.
I was just thinking about that.
Okay, here. So when we are a baby, our spine and spinal cord are the same length, but our bone grows faster than the spinal cord. By the time we are an adult, spinal cord actually stop at the L1. But then after that, all the nerves that are going to come out of our lumbar spine, they go down, they do look like a tail of a horse, hence cauda equina here. These are all nerves. They pass on the lateral aspect of the disc before they come out in a place that we call that lateral recess. Lateral recess is right here. Let's see if I can have a better picture of the axial cut. Here. Beautiful. Here. Look at that here. Now, this is the foramen. If the disc pushes here, it actually pushes on the nerve that's going out, then you have the symptom of the same level nerve root.
Mm-hmm.
But nature did it something that actually the disc is weakest in the lateral recess right here. Here, it's not pushing on the nerve that's going out same level. Here, it pushes on the nerve that goes one level below it.
Mm-hmm.
So, L5, S1, disc herniation, 80% of the time, it pushes in the lateral recess on the S1 nerve root, one level below it, and only 20% in the foramen where the same nerve is going out. So, the typical symptoms of L4-5 disc herniation, typical, is L5 nerve root, even though L5 doesn't go out in L4-5, goes in L5-S1 out. Too much information for you, Amanda, but I'm sure Dominic will appreciate that, because next time somebody comes and says, doctor, my pain is going out to the outside of my foot, outside of the foot. That is S1. Heel is S1. Then you will most likely look for pathologies in L5, S1. If they could say, oh no, I have nothing in the heel. It's all on the big toe. Big toe. Then most of the time your pathology will be in L4-5.
Mm-hmm.
Even in L4-5, even though in L4-5, actually L4 is what's coming out of there, you would be thinking, you were expecting that the symptom be on the outside of the thigh. Now, Dominic, do you know how long it took me to really understand that, the gravity of that the clinical implication of that?
No idea. How long?
It took me after the high school, after the med school, and 7 years into my diverse residency program to understand the intricate harmony and how this works together. Why is it that in L4-5 disc herniation, 80% of the time you expect top of the foot symptoms? Even though top of the foot is L5, it doesn't really go out there. And you would be surprised if you just understand what I just told you and why is it that way. You know more than 90% of the doctors in the whole world about the intricate play of the nerves, bones, and embryology. And you don't understand that until you understand embryology. Why? Because this is not the same in the neck. In the neck, it comes truly out same level. Neck, you expect the symptom of the same level, more or less. In the thoracic, it comes lower and lower. It becomes more and more like a lumbar spine. So depending, the higher thoracic spine behaves like cervical spine, radiculopathy. The lower thoracic lumbar spine, lower thoracic spine behave like lumbar spine. But you need to know a few things, okay? For radiculopathy, you need to know a few things. Obviously, shoulder is C4-5, thumb is 6, middle finger is 7, pinky is C8, Nipples are usually T5, usually T4-5. Umbilical, the belly button is T10. Groin is TL1. Usually L1-2 is front of the thigh. Outside of the thigh is L4. Back of the thigh it is L5S1. That is why one of the first questions I ask anybody in the clinic is, forget about your back pain. Tell me about your leg pain. Is it in the front, side, or back of the thigh? You hear me a lot asking that question. Now, is that good enough for radiculopathy? What else do you want to know?
I thought it was beautiful. Amanda, how do you feel?
I thought it was good. I mean,
This is no Kardashian. So this is not Amanda's cup of tea.
well, I was actually more like, I was gonna ask, what does it feel like to have radiculopathy? If someone's like, I think that I have this, what would they feel like?
So, I mean, a lot of the times the patients we see, they'll have a couple of symptoms. Sometimes they have multiple, sometimes they only have one or two. It'll be a shooting pain that kind of goes down. Sometimes it doesn't go the whole direction down the dermatome that we just showed, but a lot of the times that's where you can find out, like, oh, does it go all the way down to the back of the foot?
Mm-hmm.
You know, that sort of thing. Other times it's just numbness and tingling.
Okay.
So.
And then it's just caused by like pinched nerves and things like that, or?
Have you ever hit your funny bone on the table?
Yeah, a few times.
Do it.
No.
That is how it feels. Direct pressure on the nerve, that's how it feels.
Okay. Mm-hmm. All right. Well, I think then we did cover it.
All right.
Okay, that was a good one.
Yeah. They're all good ones. Yes.
I still went back a few million years back.
I just expect it. I always put on my travel outfit first. Thank you guys for watching. This was Essence of Medicine. Today we talked about radiculopathy. I'm Amanda Armagost.
Dominic Moore.
And I'm Dr. Abbasi for Essence. Thank you for going million years of journey for us.
Thank you.